Awesome. Yeah. So, hello everyone, and welcome to GBM Voices, our Brain Bank's educational webinar series designed to connect people living with glioblastoma, care partners, families, healthcare professionals, and advocates through conversations that inform, empower, and build community. My name is David Robles, and thank you all for joining us today. We're grateful to have Jennifer Serventi, and if this is your first GBM Voices session, welcome. We're so glad to have you here. Before we begin, just a few quick reminders. So today's session is being recorded, and Zoom AI meeting summary is enabled to help us capture the discussion. And we will share the recording and additional resources with everyone who registered after the event. And uh, we will reserve approximately 30 minutes for audience discussions following Jennifer's presentation. And it's my pleasure to introduce today's speaker, Jennifer and Serventi. Jennifer has specialized in neuro-oncology since 1998 and serves as a physician assistant and senior research associate in the Department of Neurology at the James P. Wilmot Cancer Institute at the University of Rochester Medical Center. Her clinical focus includes primary brain tumor management, quality of life interventions, and advanced care planning conversations. Throughout her career, she has coordinated more than 50 clinical trials related to brain tumor treatment and quality of life, and is passionate about helping patients, caregivers, and healthcare professionals navigate the complexities of brain tumor care. Jennifer, thank you again for being here and for sharing your expertise with our community. I'll turn it over to you.
Thank you so much, David, and thank you for having me today. And thanks to all of you who are joining on this afternoon. As David said, we're going to be talking today about advanced care planning, and the title of this talk is Thinking About It, Talking About It, and Writing It Down, because those are the three main steps that we need to go through when we're thinking about something like advanced care planning. So really over the course of all of our lives, many of us are going to be faced with the task of making some decisions about what types of medical care we might or might not want, and what kinds of interventions are acceptable to us under various conditions, right? Under various diagnoses and under various medical issues that we might be undergoing. And this is really especially relevant to patients who have serious illnesses like glioblastoma. So we may be asked in some of those medical situations what our priorities and what our values are as they pertain to our illness or the illness or the quality of life of the person that we love. We may be asked to decide if interventions like CPR or aggressive measures like being placed on a ventilator or living in a nursing home are things that we would want for ourselves or for our family. And in some cases, and in many cases, these are questions that are being asked in the middle of an acute, scary, tumultuous moment, often standing in the middle of an emergency room, in the event that something happens to our health that causes us to deteriorate rapidly. And so the purpose of advanced care planning is really to alleviate some of the stress and some of the fear that can be encompassed within those moments, both for ourselves and for our family members, by really talking through the goals of one's care, talking through someone's wishes, their priorities before we enter a crisis situation. And by having these conversations, we can really give our families and our medical teams the gift of knowledge and comfort about what's most important to us, knowing that if an acute situation like that should arise, that they're carrying out the wishes that we've really already expressed, and we're not asking those people to make blind decisions for us. I've personally been in that situation where we've had someone close to us be in an acute medical crisis and urgent, huge decisions had to be made. And I can just tell you, it's a terrible situation to be in. So undergoing an advanced care planning visit can really provide ourselves and our loved ones with a roadmap that we as the patient really design ourselves to help them through a crisis that might require those big decisions surrounding our medical care. And that's the real reason for today's talk. So the objectives of our talk today are really to define advanced care planning, explain what it is, and go over a few associated terms. We'll then talk about the benefits, the goals, and some of the barriers to advanced care planning. I will provide you with 6 steps to completing an advanced care planning visit, and then we'll go through kind of a hypothetical patient case, how you can, so you can see how that patient would do potentially with or without an advanced care planning visit. So the first definition on here is advanced care planning. What exactly is this? Well, advanced care planning is not a single visit. It is a process that really supports any adult at any age or any stage of health in understanding and sharing both their personal values and their life goals, but also their preferences regarding what kind of medical care they would want. And so while I say that this is for any adult with at any stage of health, again, it really comes to the forefront for patients with serious illnesses. An advanced directive is a document that someone completes that really indicates some of these wishes that someone might have. And so the advanced directive is kind of an umbrella term for any document that documents decisions. A healthcare proxy form, as we call it in New York State, also called a surrogate decision maker form or a medical power of attorney. This is a type of advanced directive that assigns a person, oftentimes a relative or a close friend, with the authority to make decisions about medical care for another person. And in New York State, and different laws have, or different states have different laws, but in New York State, this healthcare proxy really only becomes active if the patient themselves loses the ability to make decisions for himself or herself, or loses the ability to express those decisions. And again, different states have different rules about that. A living will is another type of advanced directive that is often completed with an attorney that really outlines some specific medical interventions that a patient would or would not want. And then in New York State, and then in some other states as well, there's a kind of a step beyond that, something called a MOLST form. Some states call it a POLST form. In New York State, that's the medical order for life-sustaining treatment. And again, this is another type of advanced directive, another type of form that's completed by the patient and a medical provider that really specifically documents end-of-life wishes. And in New York State is an actual order that can be used both in a hospital setting, but also for EMTs and medical providers to follow. And that's what some people would refer to as a DNR. And we'll talk a little bit about that. So why exactly should we be thinking about having an advanced care planning visit? What are the benefits of these visits? Well, the main purpose of an advanced care planning visit is to ensure that the delivery of care that the medical team is delivering, that the patient is receiving, really aligns with that patient's wishes and values. There's a lot of data out there showing that advanced care planning visits can help reduce hospitalizations and thus reduce healthcare costs. I think from a patient standpoint, cost is certainly an issue, but nobody wants to spend time in the hospital. And so if there are conversations that patients with serious illness can have with their providers ahead of time that can help keep them out of the hospital, that's a win for everyone. We know that advanced care planning conversations can boost the utilization of hospice services and palliative care services. And then I think you might see in my example that I give at the end of this talk that having an advanced care planning visit and making sure that everybody, like all of the players, all of the team players are on the same page can really increase harmony at the end of life for patients. Other goals, more specific goals of advanced care planning visits are to ensure that the medical care that patient is receiving aligns with the patient's specific goals and values. Advanced care planning can also help patients make decisions about what kinds of treatments they might want in the future. Would I be willing or interested in undergoing another surgery? Would I be willing or interested in being admitted to an ICU for specific treatments and those kinds of things? It's also an opportunity for the medical team to clarify some things that maybe were a little muddy or misunderstood up until then. So clarifying the goals of the therapy. Is this a therapy that we expect to cure your disease? Is this a therapy that we expect just to be palliating symptoms or just buying time? And then have also an opportunity to clear up any misunderstandings or misconceptions that patients or families may have about what we realistically expect in the future for patients when it comes to their specific disease, the treatment of their disease, but also regarding outcomes around things like cardiac resuscitation and hospitalizations. It's an opportunity for the patient to make their priorities and wishes really known to their family. So we get everybody in the same room. And it, I kind of say it's like hearing it from the horse's mouth. That daughter who's struggling with wanting mom to keep treating and keep fighting can hear from mom that maybe she's tired. Maybe she wants to change gears. Maybe she wants different things for her future. And then again, lastly, to really ensure that care at end of life is appropriate based on the patient's values, and that we're not doing things to patients at the end of life or near the end of life that they don't want. So how often are we actually having these conversations? Well, certainly not enough, and there's a lot of data showing that. So a 2025 survey of about 1,800 random American adults showed that only about a fifth of patients had ever had any sort of advanced care planning conversation with a clinician. And only about a third of them had documented those conversations. When you look at that pool of 1,800 patients, and you look at just the patients with serious illnesses, the numbers are much better. But still, only about three-quarters of those patients had had a conversation at all about advanced care planning, about values, about documenting advanced directives. And so we can definitely do better. About 8 or 9 years ago, one of our neuro-oncologists, who's now an attending here, was a medical student with here in our system, and she took a year out of medical school to work with us in the neuro-oncology department. And she did what's called a retrospective analysis, essentially a chart analysis of about 117 patients in our practice who had brain cancer. These were mostly glioblastoma patients. And what she found when she looked in their records was that by the third time we saw those patients with this very serious diagnosis, only about a half of them had any sort of advanced directive documentation. And the vast majority of that documentation was just, healthcare proxy forms, just saying who they wanted to be their medical decision maker. And somewhat surprisingly was that beyond any healthcare proxy forms, any other forms that were signed, about half of them were signed by the proxy, not the patient. So patients weren't making their own decisions, is what we were seeing. What we found was that about a quarter of patients had absolutely no documented advanced directives at all in the last month, before the last month of their life. And that only about 60% of our patients got enrolled in hospice more than a week before they actually passed away. And so we were really missing this window of care and support that patients can be getting at the end of life. And then just over half of our patients at that time actually died at home, which we know when we're talking to patients is most people's preference. And so we were definitely missing the ball here on having these conversations with patients in a timely manner. So why is that? Why are we not talking about these things with our patients? So one barrier to advanced care planning visits is role clarity. Whose job is it to bring this up and to say that this is important and to initiate these conversations? So is it the patient's job to ask for this visit, or is it the provider's job to offer it? And if it's the provider's job, which provider? And if it's the patient's job, which provider do they go to? So do they ask their primary care physician who they've known for 5 minutes, or maybe they've known them for 50 years? Do they ask their oncologist? Do they have a palliative care specialist involved in their care and they could ask them? Who do they ask for this visit? There's also a misconception on, I think, both sides of the care, both on the patient family side as well as on the provider side, that somehow talking about these things, talking about end of life, means that we're giving up on the patient, and that's not at all the case. There's a lot of reluctance to talk about really hard things, both on the patient side and on the provider side. These aren't necessarily fun conversations. I will say that we do have some laughs and we have some smiles, but we definitely have some tears. And they're hard things to talk about. So nobody's like excited to talk about this. And then on the provider side, there's reluctance because we don't we don't want to be bringing fear or anxiety or loss of hope to patients, and we don't want them to perceive us offering or encouraging them to talk about end of life as being, as it being our opinion that we're there or we're getting there soon. Um, some patients and some providers don't really understand the benefit of these conversations. And then a big systematic barrier to this is just a lack of time. As all of you know, when you sit down with your primary care provider, you get 15 minutes to talk about 10 different things. When you're sitting down with your oncologist, you're talking about your MRI results and your chemotherapy and steroids and seizures and the social issues that you might be, having at home and the fact that you can't sleep and your appetite is different, right? You're talking about all these things in that 30-minute visit. How exactly are we going to be sliding in advanced care planning? So there's insufficient time in our medical appointments. So, having said all that, knowing that there are benefits to these conversations, knowing that there are barriers to these conversations, how exactly can we then go about initiating these conversations? Well, I suggest six kind of simple steps. These first three steps in red are in red simply because they're kind of interchangeable in terms of the chronology of them. They can be overlapping and happening at different times, and we're going to go through each one of these individually. So, step one is to choose that surrogate decision maker. Who do you trust to kind of be your voice as it pertains to your medical care if you end up in the situation where you can't use your voice yourself? So, again, in New York State, that's known as a healthcare proxy. In other states, might be called a medical surrogate or a medical power of attorney. Again, most patients will choose a close family or friend, and you really want to make sure that you're not necessarily just picking your spouse or you're picking your eldest child because they're the eldest. You want to be sure that you're choosing someone who you are confident will have the ability to carry out your wishes, and don't assume that they're going to carry out your wishes simply because they're close to you. You want to be sure that you're choosing someone who maybe can detach a little bit emotionally or really just hear what you're saying, and in that moment, in that crisis, be able to turn back to those words that you said and say, yes, this is what the patient wants, and this is what I'm going to do for them. Again, the goal is for them to be your voice, not for them to be making decisions on your behalf. You also want to consider their own health issues. So, a lot of times when we're seeing patients in the office and we're asking them who their healthcare proxy is, and they say, it's, my wife, Sue, who's sitting here next to me, I'll actually turn to Sue and I'll say, Sue, who's your healthcare proxy? And Sue will often say, well, it's my husband, the patient. And then I'll say something like, you might want to think about having somebody else as your backup or changing your healthcare proxy, because having a healthcare proxy who has their own medical issues or maybe having things like neurocognitive decline down the road maybe is not the best situation. You want to make sure that when you have a serious illness and there's a possibility that someone who you've chosen as your healthcare proxy may actually have to invoke those powers, or may have to step into that role, you want to be sure that they're comfortable having that responsibility. You want to ask them permission to make them your healthcare proxy. And then whenever possible, choose an alternate person, somebody that they can use as a backup, somebody that that the medical system can turn to if they can't reach your healthcare proxy. Always have more than one person on the form. The second thing you really want to do prior to having your advanced care planning visit is to consider your own personal values. So think about some things and talk about them with your family. So, what are my priorities for the remainder of my life? So, for example, if someone told me that my prognosis was 2 years, well, what are my priorities for those next 2 years? What kinds of things do I want to accomplish in those 2 years? Think a little bit about whether quantity or quality takes precedence for you. Most people want their cake and to eat it too, right? We want as much time as possible, and we want that time to be fantastic and have really, really good quality, but that's not always reality. So, which one of those two things tips the balance more for you? And what exactly does quality of life mean to you? So, quality of life is different for everyone. And going into an advanced care planning visit with a patient, I really find it helpful to have an understanding of what quality means to them. I have had patients say to me that quality of life for them means that they need to be able to play the piano and do their gardening. And without those things, so if I can't blank, if I can't garden, and if I can't play the piano, I don't want to go on anymore. I don't want to prolong that survival. And then on the other end of the spectrum, I've literally had a woman say to me, I don't care, stuff me and stick me in the corner. As long as I can witness my family and watch my grandkids play, I'm good. And so those are very two different ends of the spectrum of what quality means to someone. Okay. What are my goals for my life and for my care? So, are there milestones that are really important for me to get to? Is my 50th wedding anniversary 8 months from now? And we've been planning this for years, and it's really important to me to make it to that. And so maybe I'm willing to take a little more risk of side effects of a treatment to get me there, right? I'm willing to sacrifice a little bit of my quality to get that quantity. um, Special occasions, births of grandbabies. I have a patient right now who I'm seeing next week, whose main goal this last year was to see her grandson graduate. And he just graduated last month. And now we're going to see each other next week to talk a little bit about whether that changes any of her priorities moving forward. Now she's kind of checked that box. Does that change anything that she wants to do with her medical care? Are there achievements that we want to check off? So are there bucket list adventures or experiences that are really important? For me, that's helpful to know from a patient because sometimes the patient thinks that, well, that's never going to happen. I'm never going to be able to get back to Florida, or I'm not going to be able to take that trip, to Memphis or Italy. And I can sit there as the provider and say, well, let's talk about that. What would keep you from doing that? And are there things that we can do and plan for to make that happen? One of the things I think I see most frequently is moving things like weddings up. Patients with kids who are scheduled to have a wedding, next fall, we can talk about that a little bit, and sometimes they can alter their plans. Thinking about what your fears are before you go into an advanced care planning. Are you afraid of pain? Are you afraid of what comes after death? Are you afraid of the burden you might be to your family? Those are things that are often weighing on the patient. They're often not expressing those fears. And so bringing those up in advanced care planning can be really helpful because sometimes we can dispel some of those fears. And then just kind of thinking about what would bring meaning to your life in the time that you have, whether that's, a prognosis of 3 months or 3 years, what would really bring meaning to that time for you? You also want to consider your end of life values. So, what kind of setting do you picture yourself in when you're passing away? Do you picture yourself at home with your family caring for most of your needs? Here in New York State and specifically in Western New York, we have these most amazing facilities called comfort care homes where patients can go to spend their last couple of months. Not every community has these. We feel very, very fortunate to. So for us, we talk to patients a lot about whether a comfort care home would be something they would consider. What about a nursing facility or a hospital passing? Would that be acceptable to you? Are there settings that are a hard no? Like my grandmother died in a nursing home and I watched it and it was terrible and I don't care how good the nursing home is today. I don't ever want to be in a nursing home. Those kinds of things. Who do you see caring for your basic needs at the end of life? So you want to be sure that the patient's idea of who might care for them at the end aligns with the family's idea because sometimes there's dissonance in that. Are those people that you expect to care for you at the end of life, are they physically and emotionally capable of doing that? And is everybody on the same page? And so these are some very specific questions to think about. So do you prefer a plan of care that focuses primarily on extending your life as much as possible, even if that means that you're more uncomfortable? Or would you want a plan of care that really focuses on alleviating pain and discomfort, even if that means not living as long? In your current state of health, Would you want aggressive measures like CPR or a breathing tube or a ventilator? Um, and then would you want aggressive measures if it meant that if you survived that acute issue, that you would be confined to bed or dependent on others for your care? These are all things to think about. So you've chosen your surrogate decision maker. You've started thinking about your values. We need to start the conversation. We need to start talking about this with someone. There's no right or wrong time to start this conversation. So, really, any adult patient, even those of us in good health, should really be talking about this with our families. That could be early in the course of a serious illness. It could be later when perhaps disease has recurred or first line treatments have failed. And near the end of life, we want to make sure that we're revisiting these conversations. We know that cancer is unpredictable. And so, in our practice, we are really pushing to have these conversations with our glioblastoma patients within the first 2 to 4 months of their diagnosis. Especially again, because I had mentioned earlier that neurocognitive decline issue that we can see in patients with brain tumors. We want to be sure we're having these conversations when the patient themselves can really participate fully and make some decisions for themselves. And then there can be some helpful conversation starters. These are just two. So if you yourself are the patient and you want to start talking with your family about it, and say something like, I know this isn't easy to talk about, but if I get sick or I have an accident and can't make decisions for myself, I want to share with you what's important. And then the second one is just if you are a care partner and you're speaking with your patient and you feel like this is stuff we got to start talking about, you may be saying something like, I've been wondering what would be most important to you if you weren't able to speak for yourself, and ask some more of those specific questions. So you need to have a conversation with the medical team. And really, if this conversation, if this process has not been offered to you and it's something that you feel like would be beneficial, you want to approach this with your team. You want to ask for this. So think about who on your team knows your disease really well, knows your diagnosis, and has experience with other patients who've gone through it. But then who are you most comfortable with? Who do you jive with? Who do you feel a connection with? Maybe it's again, it's your PCP, maybe it's an oncologist, maybe it's not a physician, maybe it's a nurse or a physician assistant or a nurse practitioner. And you want to ask for a dedicated advanced care planning visit. And I carve out an hour for all of these visits. I have never had one go short. I have had them go long. And you want to ask them if they feel capable of helping guide you through this conversation. You want to plan a time when this is really all you're talking about. I mean, you can spend 5 minutes at the beginning just talking about a symptom that popped up recently and maybe put a pin in it and come back to it later. But you really don't want to be taking any of this dedicated time to talk about treatments or medications. You really want to focus solely on this. You want to be sure to include important people in your life, generally adult people in your life, who you think would be helpful adders to the conversation, but also people who you think need to hear this. All right. And you definitely want to be sure to try to incorporate your healthcare proxy or your surrogate decision maker. And again, prior to this, consider all of those questions going into it about what's most important to you. We here in our center do in-person visits for this. We do virtual visits for this, and a lot of times we're doing a combo of the two. So we'll have the patient and the primary care partner in the room, and then we're Zooming friends and family from outside. So key items to discuss are your prognosis, to clarify that, what the goals of your treatment are. So is this something that we're thinking is curative or palliative? What are my realistic expectations for improvement of how I'm doing today? You want them to, when you're really getting to the nitty-gritty about resuscitation orders, you want them to explain to you what that actually looks like in real time. And you also want them to discuss what their realistic expectations are of you surviving cardiac or respiratory arrest, given your specific medical situation. And then what do they think life would look like after you survive this kind of event? I find that conversation to be the most helpful because I want patients not only to know that surviving cardiac arrest is rare, all right, about 24% of patients who have cardiac arrest are able to be resuscitated successfully. But I also want to be able to explain to my patients who've had brain surgery, radiation, have a large mass, already have some cognitive deficits. I want them to know what life might look like on the other side of surviving something like that. And then you want to complete the forms. All right, these are just two examples of the New York State forms. You want to complete the healthcare proxy form. If you've made any decisions about resuscitation, you want to get those forms completed and filed. And then the fifth step is to make sure that all of the key stakeholders in your life are aware of any decisions you've made. And so you want to be sharing copies of these forms with different medical systems. You want to review the forms with your healthcare proxy if they weren't able to be at the visit, and ensure that whatever decision you've made, that your healthcare proxy feels that they could go ahead and carry that through for you. And then the last step is really to adjust over time. Things change. We reach milestones, we have changes in our health. Maybe there are changes in treatment that are not available to us. And so we want to continue to address these questions with our medical team with time. And so with that, I just want to close on kind of giving you an idea of what an imaginary patient's experience may be without an advanced care planning visit, and then we'll go back through his story if he had an advanced care planning visit. And while Tom is not a real person, Tom is kind of a Frankensteining of some of my patients, and so what I'm going to go through with you is not all that far from some of the truths that I've seen patients and their families experience. So Tom is a 72-year-old widower. He was diagnosed with glioblastoma recently, and he's doing quite well. 18 months prior to his diagnosis, his wife was diagnosed with congestive heart failure and passed away. And Tom really took care of her throughout the course of her disease, and she had a really hard course, and her health kind of slowly deteriorated over time, and he provided all that care for her. They had healthcare proxy forms written up years ago with their attorney, and they both indicated that each other was their primary healthcare proxy, and then their eldest daughter they chose as the alternate. So Tom and his wife had two daughters, Sue and Amy, and they're not terribly close. Sue is the eldest daughter. She lives in Pennsylvania. Tom and Amy live in New York State. So Sue lives in Pennsylvania, and she really struggled with her mom's passing. It was very traumatic for her. It was very difficult, and she continues to mourn her mom's passing. Amy lives locally. She takes Tom to all of his visits, all of his radiation treatments. She's very supportive and very well informed about his diagnosis. Driving him back and forth to radiation for that 6 weeks and taking him to his appointments. They have a lot of conversations in the car. And Tom has talked to Amy a lot about his end of life wishes and his values. And Tom has expressed to Amy that he really, after seeing what his wife went through and with his diagnosis, he really doesn't want significant heroic measures at the end of life. And he definitely doesn't want any sort of prolonged suffering for him or his family. So Christmas comes and Sue is visiting from Pennsylvania, and unfortunately, they're out to dinner, and Tom collapses at dinner. They take him to the emergency room by ambulance, and he's found to have had a stroke. Because of the stroke, he's really unable to consent to anything. He's unable to communicate his wishes. And remember that Sue, his wife, was his healthcare proxy, and she's passed away. Sue is his alternate, and she's the older daughter. Tom's condition in the emergency room deteriorates. Amy tells Sue she's had conversations with their dad, and Tom doesn't want heroic measures, and Sue says, I don't think he really meant it, and I can't just let him go. And so based on Sue's recommendation or Sue's decision, the emergency room staff intubate Tom, they place him on a ventilator, and they admit him to the ICU. 3 weeks later, Tom is still in the ICU on the ventilator. He's really made no improvement. Ultimately, about a month after his stroke, the medical team, along with the two daughters, makes the decision to take the breathing tube out, and Tom passes away. And throughout the course of that entire ordeal, Amy and Sue, who were already not very close, really grew further and further apart over the discord over Tom's care. So not a great outcome for anybody. Tom got care he didn't want, and these two girls have grown further and further apart. So we're going to now talk about Tom with an advanced care planning visit. So same story we just went through. So Tom has this diagnosis of glioblastoma and he asks his oncologist for an advanced care planning visit. Amy accompanies Tom to that advanced care planning visit, and then they Zoom Sue in, right? So Tom is able to express to his daughters and the medical team what his priorities and his wishes are based on his values and his past experiences with his wife. And he tells the team that he really doesn't want heroic measures if something catastrophic occurs. Both daughters hear this, they understand it, but Sue admits in that visit that she's not sure she'd be able to make that call. She's not sure that she'd be able to let him go if the time arose. And so in that visit, Tom hears that and he decides to make Amy the healthcare proxy, and then Sue is the alternate. Okay. And he fills out a MOLST form indicating do not resuscitate, do not intubate. So the same thing happens with the stroke, but this time, when he gets to the emergency room, the hospital has his DNR, DNI form on file. They confirm with Amy, the healthcare proxy, that they should follow that DNR, DNI, and she says yes. Instead of being placed on life support systems, instead, Tom is admitted to the inpatient palliative care unit, and 2 days later, he dies peacefully with his daughters at his side. And through that process, Amy and Sue actually become closer after sharing Tom's peaceful last moments together. So, two very different outcomes, not only for Tom, but for the harmony of this family. So, in summary, I hope that you've learned a little bit about advanced care planning and what it is and how it can really provide a roadmap for making decisions about one's future, really based on our own personal goals and values. And this engaging in this visit can really help ensure that the medical care that one receives is concordant with their own values. And those values can change over time, and therefore so can the documenting of wishes. And completing this advanced care planning process can really be a gift of providing that knowledge to your family and your loved ones and removing a lot of burden of that decision making in a crisis from them. Thank you so much. I am happy to take any questions that anybody has about all of this.
Awesome. Uh, Thank you, Jennifer, so much, for this wonderful presentation. And we'll, take a few minutes just to see if there's any questions, additional questions that come in from today's audience. If you have a question, please feel free to submit in the chat. We'd be happy to answer it. And while we give, everyone another moment to think, I'd like to start with a few thoughtful questions. Oh, sorry.
I just wanted to, hi, Jen, this is Kelly Dupre, Executive Director of our Burn Bank. Sorry at the beginning. For some reason, my internet was really unstable. I just want to say lovely presentation and thank you very much for doing it. And to everybody else on the call, we relaunched um, these educational series about 6 months ago, and this one was extremely thoughtful. And your case study was just so spot on because I've just seen this happen so much, and it's so true. I mean, your case study was just like so like. I mean, it was just, I've just seen it happen.
You can just see it happening, right? You just.
No, I have seen it happen.
Yeah. Yeah.
And it just points out exactly why it's so important to have these conversations right now, even like when you're healthy. I mean, people need to have these conversations with their families.
Absolutely. I tell patients all the time, when they're reluctant to talk about this, I just hit 50. I've got young children. I'm healthy. But my husband and I have sat down and talked about this. Like, if this, then this. These are the things I wouldn't ever want. These are the things that I would. And of course, it's a little bit, it's nebulous when you're talking about it outside of a specific serious illness, but sitting down with your medical provider and really putting it in the context of what diagnosis you're actually going through now can really help make it kind of more tangible, so that you can make real decisions and have real conversations about it.
Yeah, I mean, my husband and I, we are too. We're just I just turned 60 and we're updating our wills and our estates too. So, I mean, because you look back like when we did them like 10 years ago and things have changed,
Yeah.
it's interesting, so it is good to to update them as
Yep,
frequently as you possibly can, because things do change in your life.
of course. David, I do see a question about sharing my slides. I'm happy for you to do that. That's fine. You're welcome to email
Okay,
those to any participants.
perfect. Thank you. So yeah, I will add that in the resource bundle. And then we also have another live question from one of our attendees. Um, yeah, they asked if a person has a DNR and you're the healthcare proxy or family member and EMTs are called during a medical emergency, is telling them there's a DNR enough, or do they need to see the actual form? If someone doesn't want CPR, how do EMTs know that?
That is a great question. So, my understanding in New York State is that by law, the EMTs need to see evidence of the form. I do know that there have been situations where just by being told, like, my dad has a brain tumor, he's DNR, that they in some situations have taken the word for it, but you don't know that you're going to get that EMT who's going to take your word for it, right? And they have to protect themselves and their licenses as well. And so what we generally recommend patients do is, yep, James, absolutely. You took the words right out of my fingertips. So you want to make sure that that MOLST or POLST form is hanging on a wall near the front door or in a sleeve on the refrigerator. The other thing that so in New York State, they're a hot pink color, and so they're meant to catch the eye of EMS. But the other thing that I recommend that the people who are with the patient the most do is take a photo of it with their phone and tag it as a favorite, and then they can pull it up in their photos. Um, and then in areas where there are multiple hospital systems that a patient might end up in, should they be taken somewhere by an ambulance, be sure that it's also in the other medical system. Nobody's walking around with this in their pocket all the time. So that's just not realistic. But those are the best ways to stay protected. Now, if a patient wants everything done, like if they want cardiac resuscitation and they want intubation, then they really don't need to be having that form, at the ready. It's still important and helpful to have it filled out so it's in the medical system, but they don't have to worry about carrying it around with them or having it on the fridge because they're going to get resuscitated anyway.
Awesome. Thank you, Jennifer. Yeah, I'd also like to continue with a few of the thoughtful questions that we received during registration. One of the most common themes we heard was around starting, these conversations. One attendee asked, how do you start the conversation while remaining honest and maintaining an empathetic approach for someone who's nervous about bringing this up for the first time? What advice would you give them?
Yeah. So I'm often nervous. I mean, I've been doing these conversations proactively with patients really since COVID. That was what sparked our group to start having these conversations proactively and not reactively, when the tumor is grown or we're getting close to needing hospice or something. We realized we had all of these patients with brain tumors who could potentially end up ventilated in ICUs, and we'd never talked about this. And that kind of put a spark under us. But having said that, 5 years of having these conversations and offering them and encouraging them, I'm still nervous. I kind of still take a deep breath before I go into it. The best way I explain this to patients and families that I think they can really understand what we're doing here is I use a metaphor that one of my former nurses came up with. And she would say, if you're going to get married in June in Western New York and you want to get married outside, you are going to be hoping for the best. You are going to be hoping that there's sunshine and a light breeze from the south, and that all of the flowers are going to be in bloom. And that's what you're going to plan on. You're going to plan your entire wedding around the fact that the sun is going to be shining. But sometimes it rains. And so you're going to rent a tent just to be safe so that you can have your wedding under that tent. And that's what we're doing today. That's what we're doing with an advanced care planning visit. We are renting the tent. This is not to say we're not going to have a good outcome. This is not to say we're not going to get you into that long-term survivor group, or we're going to get you, to reach those goals that you have for yourself. But this is kind of an insurance policy. And so I offer that to patients and families, and then I say, we're going to talk about these really hard things for an hour, and then we're going to file it away, and then we're going to beat the crap out of your cancer. And we're going to keep treating as long as you want to keep treating, and we're going to, keep positive. And so I have really found for patients and providers that having that 1 hour where we kind of get it all out and we get some of the elephant in the room, you know, into the light can be really helpful. And then people can file it away and then they move on.
Awesome. Thank you, Jennifer. And another attendee asked, how do you cope with scan anxiety and living with
Mm.
an expiration date? Do you find that advanced care planning can actually help reduce some of that uncertainty or anxiety?
Oh, that is a thoughtful question. Scanxiety is real, and it is almost universal. It is rare that I am sitting in a room with someone who's not a little nervous about their scan. Um, I think that, I tell my patients that I give them permission to be anxious for 48 hours before their scan. You can be worried in those 2 days before you have an MRI, but between those dots, you're living your life and you're doing your thing and you're not focusing on it. Um, I definitely think therapy helps. I encourage a lot of my patients to get therapy so that they can be talking out some of those existential fears with a professional who is, trained to help them cope with that. Talking with other patients and getting support through support groups, through venues like this can be really, really helpful. I'll be honest, I don't think we've delved a lot into scanxiety during an advanced care planning visit. We're talking in these visits about um, we're not talking as much about what I would think of as like kind of the minutia of GBM care. That's something that's happening so often, and it's not a crisis, though it can feel like one. Especially when you get bad news, it definitely feels like a crisis, and sometimes it is. But I think that the best way to deal with scanxiety is just to talk about it and just to talk to other patients who feel it too.
Thank you. And another attendee asked, what should caregivers do when their loved one can no longer safely navigate the home or they can no longer physically help them move safely?
Mm. So that's definitely something to talk to their medical team about. So we always want to be sure, safety is number one, but safety for the patient and safety for the care providers, right? So we want to be sure if a patient is really struggling physically at home or even cognitively at home, so sometimes the patient can get around just fine, but they're doing things like leaving the stove on or leaving the door open or operating a vehicle when they shouldn't be. So if there are safety concerns of any kind, that should be brought to the medical team. Sometimes that means that we need to help encourage families to find additional professional supports in the home. Sometimes it means just making some suggestions and giving some ideas about how to find other friends and family who want to help and can be there in the home. Sometimes it means that it's just not safe for the patient to be at home anymore. And those are some really big conversations to be having with the medical team.
Thank you. And then another question we received was, how do you know whether fatigue is caused by the brain tumor versus something else?
Fatigue is a tough one because fatigue is caused by a lot of things that brain tumor patients are going through. And sometimes we never really figure out exactly what it is, but it's usually a combo of having had the brain tumor itself. Definitely radiation therapy causes fatigue, not just in the short term, but in the long term as well. And then medications like seizure medications can cause fatigue. Anxiety medications can cause fatigue. And then we can get just fatigue from what's called deconditioning. So just not being up and around and as active as we're normally used to. We can get some, muscle wasting from that, and that makes people more tired and more fatigued. Then I think the other thing is sleep patterns. So sleep patterns in patients with brain tumors are often disrupted, and so patients aren't sleeping as well at night, napping more during the day, and maybe not getting the deep sleep that is really restorative that we depend on to be able to keep up our energy. So there are a lot of things that cause fatigue. Teasing out what is causing the most fatigue in a particular person is challenging. But sometimes the medical providers can play around with medications to see if they might be responsible for that. But again, something that your medical team needs to try to help you figure out, recognizing that sometimes the answer is we're not exactly sure. And we're just doing our best to try to treat the fatigue as best we can.
Thank you. And then one registrant asked a broader question. Um, is there reason to remain hopeful about future advances and the possibility of better outcomes for people living with glioblastoma?
There's always reason to remain hopeful. So, as David had introduced me, I've been a physician assistant and researcher in neuro-oncology for going on 30 years, which is crazy to say out loud. Um, we have made significant advances in that 30 years, certainly not nearly enough, but I will say that the advances we've made in the last decade have been kind of the most encouraging. And the rapidity with which we're identifying new things, new targets, new understanding. We're getting better at imaging. We're getting better at surgery. We're identifying more accurately why certain patients are responding differently to different therapies. And then, as much as my children would hate me for saying this, the advent of AI. My teenage kids are very, very anti-AI, which I think many of them are. Um, I think that we're going to see really remarkable things come out of that in the next 5 to 10 years. I don't want to hang my hat on saying we're going to find a cure for this in the next 5 to 10 years. I would love that if we could do that before I retire. But I think we're going to make really significant breakthroughs for advancing survival and hopefully even improving quality of life by using those tools and building on the research that we've made up to now. And so, yes, there's a lot of reasons to remain hopeful.
Thank you. And then we have another live question. Elena asked, how do I go about finding someone to help with advanced care planning?
Yeah, so you got to think about who are the people who care for you now. So is there an oncologist who cares for you? Is there a primary care physician who cares for you? If there's not someone in those kind of two buckets who you feel close to and comfortable with and who you think maybe has the demeanor and bedside manner to have this kind of conversation with you, then you could ask for a referral to a palliative care specialist. And even a palliative care specialist who you've never met is well equipped to go through an advanced care planning visit with you.
Thank you. And before we wrap up, what's one message or piece of advice you hope everyone leaves with after today's discussion?
Think the biggest message here is that patients with serious illness can have scary things happen that are unpredictable. And the best thing that we can do for the people who love us as patients and are caring for us as patients is to put on our big kid pants and have really hard conversations about scenarios that could happen down the road, so that we can make sure that everybody is cared for and heard and understood and feels safe in that moment and can sleep at night knowing that they made the decision that was right for everybody.
Thank you.
Great. This was excellent. Thank you.
You're welcome.
Thank you, everyone, for attending. We hope you found this series very helpful. We will be taking a break in August because we know people will be taking a lot of vacation, and be on the lookout for our topic in September. Have a great rest of your summer, and we'll see you in September.
Thanks, everybody.
Thank you
Have a
very
great summer.
much, everyone. Thank you.
Thank you.
Bye.
Bye-bye.